Good afternoon, everyone. As we all know, today's discussion is all about AMSP as we do it in AIIMS Patna. And today's presentation is divided into three parts. The first part will be discussing the essentials or essential components of AMSP, what we need. Primarily, the focus would be on our form, which is the most important thing, I believe. And second part, we would go and discuss things that we have achieved in the last 1.5 years in AMSP, after we started this AMSP rounds, and with few examples. And third round is the most interesting part, where we would be simulating two cases. So we would be pretending to be the ICU and all of you will be the stewards, and we will present two cases with day 1, day 2, day 3 findings with lab parameters and all those things. And we would be discussing two cases. All right. So before we get into the main corpus of the presentation, I would like to discuss how this AMSP actually came to be. I still remember it was the monsoon period of 2023, where it was a similar presentation like this, where sir, after like discussion, said that we would be starting a new rounds called the AMSP rounds, stewardship rounds. And we will be starting with the new batch. I mean the exam going batch, which was me, Swati, and Anirima. And it started on in again the July-August period. So the first, and we remember that the initial parts we were like really nervous because we didn't know anything of anything. Because in the lab we were always protected. So even if we go for clinical rounds, we take the information, come back here, and there it is discussed, and the final report then goes away. But in case of AMSP, we were going and interacting with the other departments. So anything we say would be somewhat recorded, formally or informally. So for the first entire duration of the first, when we three were going, we were always accompanied by a faculty, be it sir, Ketan sir, anybody. So they used to say, what is this, and like we were like toddlers. Like we used to ask, like, sir, what is this? So, and then I think we have come a long way, and we have put an imprint in the ICU, and also we have got to learn a lot of things which we theoretically used to say that these things are not done and why this is not done. So we got a maturity in terms of. So before we should start with the AMSP rounds. So in AMSP rounds, what happens is that after our reporting is over or nearly over, we go to the computers and we take the data of all the patients that are available. So this is, let's say, not the first day of any patient. Say, since it's been going for quite some time, we already have the records of the patients of the previous day, right? So we go to the patients, we go to the computer, go through the HIS and find all the reports before going in there. And also the findings that are yet to be published in the HIS. So let's say the sputum reporting would just be over, so the entry and validation would be finished by 1. So some of the sputum reportings would only be built for culture and sensitivity. So we would also give them the updates with respect to the gram stain reports or stuff like that. And then we go to the MICU, C1B, and there we start gathering data, the basic data. After the basic rounds are completed, then we wait, and the things that we can compute there itself. Like some of the things we know that the loading dose is not given. 2 broad spectrum antibiotic with overlapping spectrum is added. Those things like a common thing right now. We discuss those things with the JR, and most of the time, 70-80% of the times, JR understands and changes it immediately. But sometimes, as I said, there's an understanding from our part too, because we say that do this, why aren't you sending the PCT or stuff like that every day? So they say that it's not possible for the patient. Financial, it's not possible. Some drugs are not there in our dispensary and all that stuff. Again, as I said, the main player of the whole AMSP round is the form. So the form will be discussed in detail by Jogi.
So we have created antimicrobial stewardship form. We have circulated the forms. This one is the field form. And I'll be talking about the components, what all things means in this form. So day 0 is the day when the patient was admitted in the MICU. Now currently only we are doing AMSP rounds in MICU, which is an 11-bedded ICU. So day 0 will be the day when the patient was admitted in the MICU. Most of the times the patients come through emergency, or they can be shifted from wards. So the date of admission may vary from the date of admission in the ICU. Date of admission according to the HIS when the patient is presented to the AIIMS Patna facility. Then patient name and the CR, the central registration number, then the bed number of the MICU, and the comorbidities if any associated with that patient. Then primary diagnosis, on the time of admission, what primary diagnosis they have made, and then if that diagnosis is of infectious etiology or not, we have to tick cross. Yes. Then most common pathogen according to that infectious etiology. Then history of prior hospitalization, maybe the patient was in ward or any other hospital, so that we have to write also. Then past antibiotic history, in the past 30 days what all antibiotics he or she has taken, so that also we have to write here. Then the devices, like the patient, which most of the times they come with altered sensorium, and in view of that the patient will be intubated. Then after coming to MICU, they will be put on central line, then urinary catheter. All those dates we have to mention, so that we can find out what the healthcare acquired infections are. Then investigation wise, the baseline investigations we have to write. For example, the total leukocyte count, neutrophil percentage, lymphocyte percentage, then the C-reactive protein, procalcitonin, then urea and creatinine, and also the creatinine clearance we have to calculate. Based on that, we can adjust the renal dose of the ongoing antibiotics. So on day 1, we have written the primary diagnosis, but that diagnosis may be updated on the basis of the lab reports next day, which we get from different departments. So write the diagnosis, if it is updated or not. Then we'll look for the updated reports also. For example, TLC, what is the trend of the TLC, CRP, and if they have sent for procalcitonin also, so that we can see the trends. Then on day 1 also, if there is any investigation which requires to be done, for example urine sample or blood stream infection, most of the times they will write sepsis with modes. So if there is central line, then we'll ask for paired sample, for one from venipuncture, one from the central line. So those advice we give. Then we'll look for what all antibiotics are going on. Maybe the patient was in ward, but we'll start counting from day in the MICU. All the antibiotics we'll be writing. On the next page, we can see that antibiotics, what is the dose, what is the route, and if loading dose is given or not, if it is required, means if it is indicated for that antibiotic. Then that the indication of that antibiotic, empirical or it was definitive based on the AST report or prophylactic, and start date. We can see different boxes are there, day 1, day 2, day 3. Based on that, we'll keep on cutting so that we can know okay, this much days of antibiotic we have given to the patient. So this is the basic thing, and after this all we also go to the HIS to look for all the updated reports prior also, after finishing our lab work, and then we go to the MICU.
Vice Steward, you are not a dictator ki you will advise and you will listen.
Yes.
You just discuss and you will say your point of view ki this may be done. But a clinician have the right to decide.
Yes, sir. We started in mid year of the 2023. The baseline was there, and after our starting MSP, we have achieved many things. So for example, they were most of the times they will keep on advising on empirical like colistin, vancomycin, tigecycline, these all things. Calculation of the creatinine clearance, and accordingly the renal dose adjustment was not done at that time. For sample collection, most of the times if the patient is already having the central line, they only used to send from the venipuncture and or only from the central line, means the single blood culture. So we discuss it, and we have also done a mutual class with our HODs are also. So after that class and that intervention, the number of paired blood culture which we received increased drastically. Then there was overlapping antibiotics, for example anaerobic coverage along with metronidazole and piperacillin-tazobactam, or metronidazole with meropenem. These were overlapping anaerobic coverage. And then for CNS, drugs should be in higher dose. Then procalcitonin, only single test they used to send, because we have to see the trend of the procalcitonin level. Then urine catheter, in case of urine, for example, the patient is having urinary catheter for longer times. So we ask them to change that urinary catheter, and then after that send a repeat urine. Then loading dose in most of the cases was not there, but now more frequently we have seen that loading dose is mostly given for all the antibiotics which are indicated. They'll write is query TB. So we ask have you sent for CBNAT or not. Then we'll again confirm it, sample has been received or not, and then again we'll just communicate with JRs there. Earlier, most of the times they used to prescribe colistin only. Colistin needs renal dose adjustment, creatinine clearance level, we have to calculate. Now we have seen that polymyxin B, which doesn't need renal adjustment. Indications of colistins are like in CNS, pyelonephritis. So polymyxin B use is now increased compared to the colistin. So these all achievements we have achieved till now. And
he has correctly said the achievement. I would just like to add one or two efforts and further nitty-gritty of it. जैसे कि initial days में the difference between the absolute use of colistin and polymyxin B was not there. Initial days में they used to call us. So consecutively 2 महीने के लिए हम लोग 3 महीने के लिए हम लोग गए. तो उसमें एक था कि कोलिस्टिन का स्पेसिफिक यूज़ क्या है, उसमें डोज एडजस्टमेंट का क्या ज़रूरत है, और उसके लिए जो डायलिसिस के पेशेंट है उसके लिए फर्दर डोज एडजस्टमेंट का क्या है, एंड व्हेन टू यूज़ कोलिमिक्सिन बी एंड व्हेन टू यूज़ कोलिस्टिन, दैट वाज critically discussed with them and they all agreed. And we also conducted the same session on the very same day here also, so that before preaching we know what we are preaching. And for that we have to read a lot in the pharmacology and medicine. So that is the extra effort we all together did. फिर और उससे पहले ही हम लोगों ने 2-3 सेशन रखा था हाउ टू इंटरप्रेट ए लैब रिपोर्ट, क्योंकि उससे पहले बहुत सारे कॉमन क्वेश्चंस थे कि कौन सा ज़्यादा सेंसिटिव है, कौन सा कम सेंसिटिव है, हाउ टू डिफरेंशिएट ए कोलोनाइजर फ्रॉम ये. तो बिफोर वी स्टार्टेड एमएसपी राउंड टू बिल्ड ए रैपो, we started few interactive sessions where 2-3 faculty from microbiology including myself and many resident and many of their student, all of their JRs and SRs were there. In those I think we looked confident, our resident looked confident, interactive enough, which gave a base for the frontal attack of stewardship.
I think one of the biggest achievement that we, I mean, at least personally, I thought was a perspective, a different perspective altogether. Because whenever we went there, we thought this is not done, this is not done. But once we go there in the field and see how things are done and why things can be done, and if they are done, and things that cannot be done and why they cannot be done. For example, in terms of PCT, a lot of people like we said PCT regularly bhejo up, because if you're not sending PCT, like we can't get a proper trend and then we can't estimate ki it's an infective cause, it's going down or not. But most of the times what happens is the patient cannot afford. So that outlook itself would not have been there if I was sitting in the lab. Secondly, there are a lot of things, as we said, like there used to be an overlapping coverage. If you go now, 1 or 2 patients who are like critically ill, they have one polymyxin with a nebulization colistin, with a meropenem, with a pipzo going on. But once we go in and we talk to the residents, they completely understand that this is not rational. But they say that we cannot do anything at this point because we believe that these drugs are keeping him alive at least for this period. And if we do something, change something, something might happen. So there is an actual thing there. So I think once we go there, there is an actual like shift of our perspective.
One kind of infection, but ICU में जो critically ill है, they might be suffering from 2-3 kind of infection. Actually, I personally long back suffered one of such conditions. Relative was admitted, and we identified, I think, Burkholderia in his or her blood. So he asked if he is on polymyxin or colistin. At that time, polymyxin was not available in the pharmacy. So he is on colistin. Should we stop it? Because the organism is not. तो मैंने बोला हाँ stop करना चाहिए. And they actually stopped colistin and started some definitive treatment for that year. Now patient expired after 2, 3 or 4 days, and by that time we also found that he was having frank ventilator associated pneumonia with pan resistant organism. So हमारा interaction हुआ था with respect to BSI, but now we have a patient with BSI जहाँ पे तुम्हारा कोलिस्टिन या पोलीमिक्सिन बी का कोई रोल नहीं है, but he is also having a ventilator associated pneumonia जहाँ पे मतलब नेबुलाइज्ड कोलिस्टिन का एक बड़ा रोल था जो हम मिस कर चुके हैं. सिमिलरली जो सब ऑप्टिमल डोज था और ऑप्टिमल डोज है वो तो करेक्ट भाई, साथ ही साथ मोर वेपोराइज्ड जो कोलिस्टिन वो मतलब वो कंट्रोवर्शियल है, लेकिन द ऑर्गेनिज्म दैट वी आइसोलेट आर सो रेजिस्टेंट दैट नथिंग इफेक्ट. तो वेपोराइज का भी डोजिंग का जो लोडिंग डोज का ये था बहुत कम था. दैट हैज इम्प्रूव्ड ड्रामेटिकली आफ्टर आवर इंटरवेंशन.
These are two cases where we feel like we have intervened, and I think this was like a holistic approach. So we recommended, they applied, and also they gave us feedbacks and stuff like that. So these are two cases. The first case was for 52-year-old female who was admitted the ward late January 2024, and the first week of February she was sent to the ICU, and the provisional diagnosis was sepsis with AKI and right lower limb cellulitis, and she was on AG line and catheter in the ward itself, and after on the second day of the ICU she was ventilated. Her baseline findings were with the WBC TLC count was 12K, CRP 238, urea 52, and creatinine 2.6. Now, initially, I mean, the diagnosis of sepsis with MODS with right pleural effusion was made, and the counts were very high. Like, okay, first we go there, we find out 68-year-old female with a history of hypertension and CKD. Okay, 68-year-old female, comorbidities, hypertension, CKD, urea creatinine levels 100 and 3.5 respectively, TLC count 18,000 with neutrophil 90%, lymphocytes 5%, PCT initial value was 3.5, CRP 256. The patient was already catheterized and central line. I mean, the patient was already catheterized, and after coming in, the patient was they inserted a central line. ET not yet. They sent a single blood culture from the periphery. Sputum sample was sent. Also, the initial diagnosis was community acquired pneumonia. The presenting features were fever, productive cough, and shortness of breath. Diagnosed to be preliminary diagnosis, community acquired pneumonia. And the samples they sent was blood, peripherally, and second was sputum. Okay. And the first antibiotics they started were piperacillin in empirical therapy, piperacillin 4.5 grams TDS IV, and piperacillin talgractam, sorry, and azithromycin 500 milligrams OD.
4.5 you said, no?
4.5 grams TDS. Azithro 500 OD. So end of day one, do you have any advices, or do you think there is something grossly wrong, or you want to change something with respect to sample collection, dosing of drugs, whatever?
What we have to do? We have to tell the advice.
आप लोग का कुछ input, मतलब आप लोग ये राउंड पे गए, राउंड पे फाइंडिंग मिला, और हम लोग अभी कुछ MICU के चेयर से, तो आप लोग कुछ एडवाइस देना चाहोगे हमको?
The diagnosis was community acquired pneumonia, and the patient is on now Piptas 4.5 gram IV TDS as well as azithromycin per oral 500 milligram OD. But the patient, according to the parameters we have checked for, the patient is going full for impaired renal clearance. Creatinine clearance is also, it will be high, and so that we are advising to reduce, to modify the dose of Piptas as either 2.25 gram TDS or 4.5 gram can be given BD along with continuing the oral azithromycin as per the current dosage, and the renal parameters should be followed daily. The urea creatinine values and as well as the patient condition should be followed daily.
Okay. So the advice is reduce the dosage of piperacillin tazobactam.
If the involvement of if they have diagnosed with community pneumonia,
No, this is the preliminary diagnosis. This is the first the patient.
One more
I-
thing we have down to come down to
one drug.
You want to continue with azithro and not piperacillin tazobactam, not in empiric.
Pipta should be given for a longer duration.
Oh,
Slow
slow
IV.
infusion.
Slow
Okay.
infusion.
Now you guys come back to the laboratory, check the sputum that they had sent earlier. The sputum was salivary in nature, so it was not a good sample of sputum. So again, the next day you go in and the first thing that you say, आपका sputum अच्छी quality का नहीं था, but by that time the patient had already deteriorated. उसको ET लग गया था, ठीक है? तो GCS was low. Second day पे you go, patient has drastically deteriorated. Okay, the GCS was low, which required an intubation, and उसके बाद कोई sample अब मिला नहीं हमको. ET से कोई sample मिला नहीं. मतलब day 2 में urea levels 123, 3.9 urea creatinine, TLC वर्क के 20,000 हो गया, 94%, 3% respectively. 20,000, 20K.
94.
PCT अभी भी 3.5 ही है और CRP अभी 240 हो गया. Sputum? No, sputum actually was rejected. It was like salivary in nature. अभी but उसी दिन रात को they intubated the patient, but अभी तक they didn't send anything. And X-ray में bilateral infiltrates we can see.
X-ray bilateral.
That was before the
Yeah, it was
intubation.
I couldn't. Yeah. X-ray bilateral infiltrates.
We want 80 sample and paired blood sample.
हाँ, तो आपने second day में you said paired blood sample you need
Kindly
And
send a
ET
paired
sample.
blood sample. One for ventiline and venipuncture and one ET sample.
ठीक है.
And we would like to escalate our
Escalate. ठीक है. क्या करना चाहोगे?
He was receiving piptas.
Piptas and
already
azithromycin.
picked our
लेकिन कल तुम लोगों ने बंद करवा दिया क्या?
yesterday we
हाँ, piptas तो continue किया.
लेकिन उन लोगों ने माना नहीं.
हाँ, they didn't. तो वो लोग 4.5 पे चल रहा है.
just want sample.
And patient is ventilated for 1 day. So why you are suspecting a HAP or VAP? It can be a CAP also. So that is why in the very first form, what are the common organism there, वो लिखा है कि CAP है या HAP है वो करके. If it is community occurred, the organism profile will be completely different.
One more fact that might influence you of this thing. By the end of first day, उसका जो blood भेजा था, वो भी बीप कर गया. It grew a GNB, ठीक है ना? तो ये information आप लोगों ने दे भी दिया है उनको.
And already alerted to the
Alert,
medicine.
That sample was
हाँ, जो venipuncture से आया था.
Let me comment. Group A, Group B.
Group B gave some reply. Group A has not given any reply yet.
They are analyzing the situation.
The patient's condition is deteriorating as well as the counts are rising, so that there might be a focus of infection somewhere. And we already got a single blood culture bottle only, but
That is beep.
That already beep, but still the patient is having central line since 2-3 days. I will be asking one more paired blood culture.
Okay.
I will be asking one more paired blood culture, one preferably from the central line as well as from the.
But we already know that something is growing in blood. So first thing we should know is what it is.
I will be processing the first blood bottle as well as I will be asking for paired blood culture also.
Okay.
And I will ask them to add renal adjusted dose of vancomycin also for getting gram positive coverage.
Cannot? Why?
Vancomycin for it can be since it is a community acquired pneumonia.
I don't know. I said it
Yes, sir.
can be cap. I
Yeah.
don't know.
Yes, sir. It can be capped so that.
But it has something has beeped in blood. That is GNB.
Yes, sir.
So how adding vancomycin would help you? It might be migrating from, if the focus is lung, it might be migrating from lung. Whatever there is in the blood.
So आप लोग कुछ बोलना चाहोगे? हिंदी.
Actually, since the single blood culture beeped today showing gram-negative bacilli, I can hold the vancomycin till the beeping of the spared bottle.
ठीक है.
I will advise again for the renal adjustment of piprazine dose since the renal creatinine again it has got.
Unless the change the dosage and any other
Paired blood culture there.
Paired blood culture.
The culture also we can step up the antibiotic if the patient is. We can switch to meropenem or we can go for like colistin also empirically until unless we don't get the
Colistin, why?
sir, because the counts and patient is deteriorating, it is not getting controlled by peptides plus.
But matlab colistin for the lung or colistin for the blood?
Colistin for the lungs because since new patch also
Then
is developing.
how you would
Root.
Root inhalation. I am just suggesting to step up the antibiotic either to meropenem or
IV
if you
meropenem.
Because
And
lung
with
patch.
But
inhalation.
as a double escalation, say single escalation better at or your preparation should be single escalation?
Yes, sir. It's just an advice according to the renal adjustment you should step up.
ET aspirate also from multiple.
And also ET aspirate and second thing can be sent for fungal culture also from the ET aspirate along with the bacterial culture.
When was he ventilated? One day.
End of first.
One day just
How dare ET aspirate will not diagnose the VAP. But if it is a community acquired pneumonia, ET aspirate can help us isolating the organism.
जो sputum में नहीं आया.
Sputum में नहीं है.
Do you guys have to add anything?
Patient is deteriorating. To find out the foci of infection, we want paired blood sample, ET sample, and urine culture.
And also dose adjustment.
Dose adjustment.
And we
Because
want to
it is-
escalate or continue with the same
But
drugs.
as by tomorrow we get the ST report,
Continue with the same.
we can continue because they are
No, but
giving the coverage.
Huh? Same dose,
What
but
is this creatinine?
creatinine is quite high.
It is rising, no?
creatinine rising, WBC rising, and lung में consolidation seen, and patient is intubated in view of.
Patches, bilateral patches. वो फर्स्ट डे में ही था नहीं ऐसा कुछ नहीं वो सेम पैचेस एक दिन ही हुआ है लाइक द फर्स्ट डे केम द सेकंड डे
Then
come on patient is dying so you won't advise for the reduction I mean adjusting the अच्छा सेकंड डे में आपको मतलब by the time you come back you see LF आ गया है and आप लोग उसको AST में दिया हो and third day में before going you get the
blood
AST
culture is
report
giving LF.
LF so the
We have AST report.
AST report पहले दिन पहले रात को यू गॉट द GNP इन्फॉर्म सेकंड डे में आप लोग ये लोग बोला है कि एस्केलेट करो आप लोग बोला है सेम रखो सेकंड डे में LF आया था थर्ड डे में you know that this is a I mean Klebsiella pneumoniae grew which is resistant to pipzo but susceptible to cefepime and colistin you report it as quickly as possible वो piperacillin still continue किया later on they switched to cefepime मतलब एक दिन बाद जाके cefepime में switch किया and with that they added meropenem 1 gram TDS meropenem 1 gram TDS IV colistin 7.5 lakhs international unit TDS वो स्टार्ट कर दिया
In that AST report, resistant to peptides, sensitive to
cefepime and colistin
पीटी स्टॉप कर दिया है क्या?
PP चल रहा है PT meropenem colistin चल रहा है
Day 3 है ना?
Day 3
एजिथ्रोमाइसिन
Azithromycin भी चल रहा है 4.5 so pipzo and azithro are continuing same dose they added meropenem 1 gram IV TDS IV colistin 7.5 lakh international units TDS उनका CPI स्कोर भी 8 है थर्ड डे में बोलेंगे pipzo को चेंज करके
previous the CPI is 8 था ना?
थर्ड डे में कोई चेंजेस वो अभी तक ET नहीं भेजा है पेड ब्लड भी अभी तक नहीं आया आप लोगों के पास वो बोल रहे हैं कि कमिट कर रहे हैं कर देंगे बट आप लोगों ने वो रिपोर्ट डाल दिया है मतलब 4 एंटीबायोटिक चल रहे हैं अभी
Since on the third day, the patient condition is still deteriorating, but they are still continuing the same dose of peptides. Again, we will advise for the again since it came resistant also as per the susceptibility, we will advise to stop the injection peptides as well as the peroral azithromycin. And now the patient is having probable infective foci in the respiratory lungs as well as the patient is having systemic infection. So that we'll be advising to escalate the antibiotic to nebulization colistin as well as IV polymyxin. And meropenem also they can stop since they came resistant.
Any other advice?
Blood and
Loading dose.
80 samples.
Loading dose देना ठीक है. Because उनका मेरोपेनम 1 ग्राम चल रहा था और कोलेस्ट्रॉल भी 7.5.
Those are resistant in the blood.
Addressing the stop.
They are removing meropenem.
ओके. और कोलेस्ट्रॉल को भी आप लोग डोज एडजस्ट करके ही देने को बोल रहे हो.
They are addressing polymyxin also.
Polymyxin instead of this thing and colistin inhalation.
Inhalation and IV polymyxin.
ठीक है. अच्छा अच्छा
Instead of polymyxin we would like cefepime
चले.
चलेगा और colistin inhalational.
ठीक है.
क्योंकि since it's a reserved drug sir.
तो ऊपर वाला नहीं जानना चाहते उस हिसाब से.
ठीक है. तो हम लोग डिस्कस कर लेते क्या क्या हम लोगों ने कैसे थ्रू आउट किया था. तो समरी ये था कि 68-year-old फीमेल आया था, कोमॉर्बिडिटी सीकेडी और हाइपरटेंशन और उन लोगों ने बायलेटरल मतलब फाइंडिंग में था बायलेटरल एस्पिरेट था, वो लोगों ने डायग्नोस किया कम्युनिटी एक्वायर्ड निमोनिया, राइट. और पेशेंट का मतलब प्रेजेंटिंग फीचर्स था फीवर, प्रोडक्टिव कर्व, शॉर्टनेस ऑफ ब्रेथ. तो बेसलाइन जो पैरामीटर्स थे यूरिया 100, क्रिएटिनिन 3.5, टीएलसी 18,000 विद 90% न्यूट्रोफिल्स, पीसीटी 3.5, सी रिएक्टिव प्रोटीन 256. पेशेंट ऑलरेडी कैथेटराइज्ड, सेंट्रल लाइन लगा हुआ था, कैथेटराइज पहले से था, सेंट्रल लाइन लगा था आने के बाद. उसके बाद सिंगल ब्लड कल्चर वाज सेंट एंड स्पूटम वाज सेंट, जो आप मतलब आप लोग जब शाम को आए पता चला कि सलाइवरी इन नेचर है. उसके बाद आप लोगों ने वहीं पे देखा पिप्रेसिल टाजोबैक्टम 4.5 ग्राम IVTDS चल रहा है और एजिथ्रोमाइसिन 500 OD चल रहा है. तो टू समराइज लाइक द जनरल मतलब जो रिव्यू दिए थे आप लोग कि आप तो पहले डोज रिड्यूस करो पिप्जो का रेनली एडजस्ट करके, और वी नीड अनदर सैंपल ऑफ स्पूटम /ET और ब्लड का पेयर्ड ब्लड चाहिए. डे 2 में अच्छा एंड एंड ऑफ डे 1 में हमको GNB भी मिल गया था, वो हमने बता भी दिया था. तो डे 2 में जाके देखा आप लोग सेम ड्रग कंटिन्यू कर रहे हैं, कोई हमको सैंपल नहीं मिला. क्रिएटिनिन लेवल बढ़ रहा है, पीसीटी लेवल थोड़ा बढ़ा है, CRP लेवल थोड़ा बढ़ा है. एंड आप लोगों ने फिर भी वही एम्फसाइज किया है कि आप स्टेप अप मेरोपेनम पे स्टेप अप करने बोले थे, यू वर कंटिन्यू विद द सेम ड्रग रेनली एडजस्टेड पिप्रेसिल टाजोबैक्टम. उसके बाद थर्ड डे पे हमको पता चल गया इट्स अ क्लेब्सिला निमोनी व्हिच इज ससेप्टेबल ओनली टू कोलेस्टिन एंड सेफेपाइम. तो वैसा करके आप लोगों ने बोला था कि कंटिन्यू विद आई मीन रेनली एडजस्ट करो सब कुछ, अगेन सेंड रिपीट सैंपल्स इफ पॉसिबल, और डोज एडजस्टमेंट में चेंज द ड्रग्स टू पॉलीमिक्सिन नहीं सेफेपाइम एंड इनहेलेशन कोलेस्टिन, और उनको भी रेनली एडजस्ट करके यही था. और you guys said the more or less the same thing. You want to
No,
continue?
they are not cefepime, no.
They are polymyxin B. IV polymyxin B and okay. But what went wrong? एक तो है कि after informing them the sample was poor, हमको second sample नहीं मिला, तो हमारा वो collection में issue हो गया. और वो भी initially में हमको blood का भी single paired blood नहीं मिला, single blood मिला. That is one more thing. Secondly, renal adjustment. हम लोगों ने वो भी emphasize किया कि creatinine ज़्यादा है, renally adjust dose because renally adjust करो अपने एंटीबायोटिक के डोजेज को, बट देयर वाज नो एडजस्टमेंट फॉर द फर्स्ट 2 days. वो कंटिन्यू करते गए. उसके बाद थर्ड डे में जब उनको पूरा वो मिला GNB कवरेज, सेम कवरेज को ओवरलैपिंग डाल दिया, मेरोपेनम डाल दिया, पिप्रेसिल टाजोबैक्टम वाज कंटिन्यू एंड कोलेस्टिन डाल दिया. इवन दो पॉलीमिक्सिन B इज द प्रेफर्ड वन, कि हम लोगों ने उनको टारगेट थेरेपी के लिए एस रिपोर्ट भी डाल दिया था जहाँ पे कोलेस्टिन और सेफेपाइम वाज दिस थिंग, तो वो भी है. और वो जो डाले भी है मेरोपेनम एंड कोलेस्टिन, वो भी रेनली एडजस्टेड नहीं था. सो दैट इज वन मोर.
Last, what do you like, cefepime or like polymyxin?
वो तो सर इज देयर अ करेक्ट आंसर टू दिस?
whatever we do is जिसके पास एक रैशनली हो, जो अनएथिकल ना हो, जिसका पास एक साइंटिफिक रीजनिंग हो और उस समय में बेस लगे. और वो है कि ये कैप भी हो सकता है, या बाहर अगर हॉस्पिटलाइजेशन का हिस्ट्री है विद द ऑर्गेनाइजेशन यू आर आइसोलेटिंग,
From outside, sir.
तो ये हैव भी हो सकते हैं फ्रॉम सम आउटसाइड सोर्स. अभी देख के वो लग रहा है, इनिशियली क्या आप सोच रहे थे?
कोलेस्ट्रॉल नेबुलाइज क्यों दे रहे हो? पॉलीमिक्सिन भी दे रहे हैं तो पॉलीमिक्सिन भी दे देंगे. पॉलीमिक्सिन भी क्यों नहीं देती है नेबुलाइजेशन? अच्छा वाला तो था ना, सिस्टमिक भी दे रहे थे, नेबुलाइजेशन भी दे दिए ना. Why is the question? Polymyxin B nebulization is bronchoconstrictor, so it will induce bronchospasm. So we don't give nebulized polymyxin B. We don't give intraventricular polymyxin B because it is epileptogenic. That's why intraventricular and nebulized is always colistin. Epileptogenic and bronchospasm causing is.
तो अभी क्लैप बजा